in population health at the University of Kentucky and a professor of health management and policy in the College of Public Health. So do you want to introduce yourself, April?
Yes, I'm April Fernando. I'm the Associate Director of the center that John is the director of, and I'm also an assistant professor in the Department of Health, Behavior, and Society at the College of Public Health.
And for those of you who haven't been tracking it, April is actually becoming what I was. So she's taken over all the training and supports and implementations as I've evolved into the role at the UK. So, all right. So today, this session, originally we were thinking about doing something for families first because there's a lot of interest around that. And the most interest that we get as a group is around algorithms for QRTP decision making. So, but we also get a number of other questions about and interest in the algorithm. So we thought it might be useful to kind of talk through the process that we use and recommend. And of course, most of you know me, so you know we're going to start at the beginning. So because it's always kind of, you want to frame it from the big picture and then move into the small. So so we're going to start with a measurement theory because the measurement theory is intentional, and it's intentional to be able to be used as a decision support. So the idea of all helping. So Communimetrics is designed actually for human serving systems. It's for helping systems. And the idea of helping is that it's always, no matter what kind of help, it always starts with hearing somebody's story. So if you are a helper, the first thing you want to do is hear a person's story. And so that's where you always start. Now, depending on the complexity of the situation, sometimes that's enough, but many times there's other storytellers in that person's life, and it's your job to listen to the multiple stories. So any good helper, so I don't know, for those of you who have kids or have kids that have grown up, you know that your child's story of their school is different than the school story of your child, right? And so you're listening to different stories and you have to combine those stories into a single story because every storyteller will tell a slightly different story, but it's not helpful. So one of the reasons why we have disjointed systems is we're making decisions based on partial stories told by a single storyteller. And if we really want to have integration in the TCOM sense of the world, you have to bring it together, one person, one story, multiple storytellers. So, and those stories could be a medical test, it could be a neuropsych exam, it could be a probation officer's report. There's just different storytellers in our lives. I guarantee you that different people will tell you stories about me and they're not always congruent, right? So, all right, so that's just how that works. So go to the next slide. And of course, you know that we do TCOM, right? So it's about transformations. Why don't you just give me the whole thing? So it's easier with this thing. So this is the hierarchy of offerings from Gilmore and Pine. And it starts with the simplest kind of business. So these are businesses, right? So there's only 5 kinds of businesses, and we have to decide the kind of business we are. So commodities are raw materials, fruits and vegetables, products, or when you take a raw material and produce something more readily accessible. A service is when you hire somebody to apply a product for you. Experience is when you're purchasing a memory, and a transformation is when you're helping people change their lives in some important way. So if you can kind of give the examples. So fish, you know, you get fish are a commodity. Sushi is a product. You take the raw fish and cut it up. You go to a seafood restaurant, that's a service. If you do sport fishing, that's an experience. You're purchasing a memory and teaching people how to fish. So in TCOM, our argument is that we've been running the helping sector as if it were a restaurant. So we pay people to spend time with people. We pay people to come to the restaurant and have our seafood dinner, when what we're really trying to do is teach people how to fish. And so we have to figure out together. We're actually just talking about this at an earlier session this morning, or whatever you call the 11 to 1 time. So we're talking about this, that actually nobody's quite gotten to transformations yet. So we're aspirational. Our system is designed as if it's a service system, but most of us aspire to be transformational, right? And so we're always bumping up against the inherent challenges of the system that's designed to pay people to spend time with people, designed to have access to care. So long as you have somebody in the restaurant, it doesn't matter the quality of the food, you know, you have somebody eating at the restaurant, right? And that's success. Into how do you actually help people change? How do you actually create a business that's about transformation? So that's our goal. Next slide. Okay, so this is pretty just a summary to this storytelling metaphor that you're trying to get the story. But, you know, I think one of the saddest moments of my life was when I discovered that not all snowflakes are different from each other, right? So I was taught as a kid that every snowflake is different. Isn't that a wonderful thing? It's a metaphor for the fact that we're wonderfully different from each other. Every snowflake is different. But that's not true. It turns out there's actually dimensions of snowflakes. The problem is that they melt too fast. And if you're trying to look at them by hand, you know, they're gone before you can actually find out. Because if you look at millions of snowflakes, you actually discover there's dimensionality to it, and they do replicate themselves. So every story is different, but if every story were different, there'd be nothing we could do to help, right? Nothing. Because we don't decide how to help based on how people are different. We respect the fact that they're different. We decide how to help based on how they're the same. So as you're listening to people's stories, as you're combining these multiple storytellers into a single story, you're listening to the common themes. Oh, sounds like depression. Well, I know what to do if it's depression. Or it sounds like they're having trouble with school. Well, are they having trouble getting to school? Do they get to school, but they have trouble behaving because they can't sit still? They go to school, they behave, but they're just not learning. You know, what is the school problem? So you're listening to these common themes because you know you have learned over time, and we have learned as a collective what we can do to help certain kinds of problems. So what we're really trying to do is respect people's differences while identifying these common themes. So it becomes incumbent upon us to be paying attention to these common themes of people's stories, because that's how we think about making decisions about what we can do to be helpful. The next slide, please. So this is where we diverge. So I was, my PhD is in clinical psychology and statistics. And so I actually was trained as a psychometrician. I am now a heretic. The concept of psychometrics, which is the most common measurement theory for subjective experiences, for things you can't really see and touch. The original version actually started with Francis Galton, the eugenics guy, actually. So interestingly enough, because we'll talk a little bit about that later, it's not surprising then that you have problems with bias in a theory that comes from that tradition. But anyway, regardless of that, the concept of classical test theory is that there's this population of all possible items. And classical test theory says if you can randomly sample questions from that population, you'll have a good measure. So there's a population of every question you could ask about anxiety, or every question you could ask about affect regulation. And if you can randomly sample that, then you can add them together, and a linear combination of items is more reliable than a single item. So you add them together and you can get a robust measure of whatever this unseeable construct is, anxiety. So of course that requires a certain number of questions, right? Because you evaluate the quality of a classical test, classical psychometrics, by the interrelationships among the different questions you ask. So it's autistic in its design. You actually evaluate the measure predominantly by how the different questions interact with each other, how they're related to each other. They have to fit the Goldilocks criteria. They have to be sufficiently correlated, but not too correlated. Now that creates these measures that are long, right? Because it takes a good classical test has a minimum of 30 questions. Right? So that's a good one. You can get down to 10. That's not a very good one, but that's kind of a minimum standard, but you have to have at least 10. in the 1950s. So classical test theory its origins are at the turn of the 20th century. In the middle of the 20th century, some folks in the Netherlands and then some folks in the University of Chicago evolved into what they called item response theory. So instead of saying, let's take a random sample of all these different possible questions you can ask, what if we thought about this continuum of anxiety and ask questions that are sensitive at different levels of anxiety? So we could ask a question that's not very, that's only people who are mildly anxious would answer and above, to a question that only the most severely anxious person would say yes to. So that's called item response theory. That it comes from educational research, actually. So the idea of it is, you need to learn how to add before you learn how to subtract. You need to add and subtract before you learn how to multiply. You need to add, subtract, and multiply before you learn how to divide. So if you can answer a division question, chances are that means you know how to add, subtract, and multiply, right? So there's this continuum, and you're looking for sampling of questions across this. Now, this reduces the number of items, but still the minimum is 2 questions to measure one thing. And typically, if you want a good item fit, you need 5 or 10 items to measure one thing. Now, that becomes a problem when you go into the real world, right? Because you don't really, as a helper, you don't have the time. So these theories, classical test theory, item response theory, the latter less so than the former, really come from a research tradition, which is trying to be as precise as possible. You don't really need to be as precise as possible when you're trying to help. You need to be as precise as is relevant to how you're going to help. So when people outside of the bubble of psychology tried to apply psychometric theory in practice, it didn't work very well, because you have to ask a whole lot of questions. And if you need to know a whole lot of stuff, that's a whole lot of questions. So it takes a minimum of 10 questions to measure one thing. If you need to know 10 things, that's 100 questions. If you need to know 100 things, that's 1,000 questions. It quickly falls apart on itself. So back then in the middle of last century, a woman named Virginia Apgar came up with the very first clinometric measure. I'm sure you're familiar with the Apgar, probably. It was applied to all of us in this meeting, right? So it's the measure of the health status of a newborn. So one item, right? One item is verboten in psychometric theory. You can't have a one item scale because all scales are evaluated by the relationship among the items. So it's impossible to have a one item scale in psychometric theory. That's why physicians said, forget about this. This doesn't work for us. We need to know a bunch of stuff. And so we need to have simple to use quick metrics. And so we don't buy that stuff from psychometrics that you have to have multiple items to measure something reliably. We don't think that's true. So that's where, and Virginia Apgar was brilliant and she was spot on. So it's true, you don't. And so we took that tradition. And so Communimetrics is an evolution from clinometrics. It's the idea that you can have these single item metrics that can be reliable in and of themselves. The innovation, I think, of Communimetrics beyond, Communimetrics beyond clinometrics is multiple items, and then taking the structure of the item responses one level higher. So even in the Apgar, it's ranges. You say if it's a 5, 6, or 7, it's one thing, and if it's a 4 or 3 or 4, it's another thing. And so we decided to articulate exactly what the actions were, because in a helping world, the only reason you're trying to measure something is to figure out how it might have relevance for making a decision, right? The only reason you're measuring it, the only reason you're listening to people's stories is to figure out what you can do to be helpful. So you want your measurement to fit the clinical helping process and not to fit some theory of research, right? Because it's really designing information to fit the work rather than trying to fit the work around the ways you manage information. So that's Communimetrics. If I could have the next slide. So it comes from, psychometrics comes from British empiricism. That's the philosophy of science. So the philosophy of science and British empiricism, this is probably beyond the interest of most people on this call, but just so you know, British empiricism is the idea that there is a subjective reality, and it's the job of science to estimate to the extent possible that objective reality. So that was the rage back in the 1800s and the early 1900s. And that led to a divergence from that. So the other extreme, because these things are like pendulums, right? So they're like presidential elections. They go back and forth and back and forth, right? So anyway, so the reaction to that model was Thomas Kuhn's scientific revolution, the social constructionist notion. So social constructionism, which started, so if you really want to understand current culture, look about 50 to 70 years ago in philosophy of science, and you'll get it, because we are right in the middle of a social constructionist world. So our popular culture has become totally social constructionist. So that model is there is no objective reality. It's just whatever we make up. And so the idea that Kuhn had in his book, the classic book, The Structure of Scientific Revolution, is that science is a ship sailing on the ocean. And periodically there's a revolution and people mutiny and they take over the ship and they sail it in a different direction. But the trick is there was no shores. So in Kuhn's model, it doesn't matter. I mean, it doesn't matter. You have these different revolutions and they just sail the ship in a different direction, but it doesn't matter because there's no place it's going to. Nobody believes that either. And if you've looked at medicine, if you've looked at technology, you know it's total bullshit to say that you cannot create progress. You cannot do something better by using principles of science. But nobody believes that you're actually constructing reality either. You're just doing the best you can in complex systems. And so that's what's led to native naturalism, reality theory. So that's kind of the current zeitgeist of philosophy of science, is recognizing that the person perceiving influences the perception, but there is probably something there that we can probably learn to get a little bit more accurate about, that we can probably get a little bit more precise, even though recognizing we'll never really get to the truth because we don't have the capacity to be objective in that sense. So, you know, the Heisenberg principle and all that stuff, right? So, okay. The other problem with traditional measurement approaches, and this is I would say it's a disaster when it comes to trying to take a traditional measurement approach and apply it to a decision support space, is that the traditional measures are arbitrary. You don't know what the numbers mean. You don't know what they mean. So give you a simple example. What's the difference between a 17 and a 12 on the Beck depression inventory? 5 points. What does that mean? I don't know. I mean, we could raise Tim Beck from the dead and he couldn't tell you what that means. You know a 17 is worse than a 12, but you don't really know what that means. Do we treat a 17? Do we not treat a 12? I mean, how does that work, right? So, or, you know, what's the difference between a 60 and a 50 on the CAFAS? I can't tell you. Okay, I just can't tell you. I mean, you know there's 10 points difference, but you don't know what it means. So arbitrary metrics are problematic. And now what we've tried to do, and people are always perpetually asking me, well, have you normed the cans? So the reason, or the answer, or the fast, or whatever, the reason why they ask, have you normed the cans, or the answer, the fast, is because they're thinking about it from a psychometric lens, and they're thinking, well, it's an arbitrary number, so we have to give it some meaning, because a norm is an attempt to give some meaning to an otherwise meaningless number. So you take your distribution of scores and you divide it by the mean of, you know, you subtract the mean, you divide by the standard deviation, and you get a z-score, and then you can multiply by a certain number, get like a t-score, get like an IQ, right? So then you have a distribution that you understand, right? So it all fits the bell-shaped curve, and you know where every item is relative to every other item. IQ is a simple example. So IQ, the average is 100 and the standard deviation is 15. So you know that if you're a 70, you're 2 standard deviations below. But it's still arbitrary. It becomes a problem. And as April will talk a little bit about this later, it becomes a problem in decision support because there's real problems at the margins. You know, you can't make an argument, you cannot, that a person with an IQ of 69 is fundamentally different than a person with an IQ of 71. You can't do it. Good luck, right? So, which creates a problem at the margins if you're using this kind of cutoff design to make your decisions. It's just not feasible. The other problem with traditional measures is they pay no attention to culture. They assume that a young African-American man in Compton will answer a particular question exactly like a prep school student in the suburbs of Baltimore, right? Maybe, but maybe not. Maybe even the language means something different in different contexts and different cultures. Maybe the context in which you're understanding the meaning of things changes with people's culture. So if you have no ability to understand that and how people are responding to the questions, then you're embedding cultural biases into the measurement process. And then you've got a problem when you've got these multiple stories. And traditional psychometric measurement, traditional research methodology uses the theory of or the methodology of triangulation. So triangulation is a really, really important method in science. It's the methodology that was used to confirm Einstein's theory of relativity. So it's a really important methodology. And so that is, if you want to understand the movement of planets, you measure the planet's location from different locations on Earth at different times. And you take these different measurements of where that planet is from different places on Earth at different times, and you can triangulate it so that you know where that planet is. You can measure its speed, you can measure its weight, you can measure all sorts of stuff through triangulation, right? So it's a really important concept. It got translated into social sciences, into subjective measurement states by my old mentor, Don Fisk, and his colleague, Don Stanley, at the University of Chicago and Northwestern. In their concept in the 60s called multi-trait, multi-method theory. And the idea is if you want to take this idea of triangulation and move it into, say, the helping profession, you need to get a parent report, and you get a child report, and you get a teacher report, a therapist report. That's how you do it. And then you combine those. So we've been trying to do that for, what is this now, 60 years? Nobody's ever been able to do it because you can't, because it's different people are different. It's making an assumption that everybody's the same when they're not, that youth are all replications of youth, parents are all replications of parents, and so forth. So let me give you a simple triangulation problem. So this is actually from my own experience. So my son has bipolar disorder. He's doing fine. He's actually helping run a campaign in Brazil at the moment. So anyway, so when he was a teenager, now I experienced, so my history is working with really, really complex need people, homeless people with substance use and major mental illness, that kind of folks. So my experience of my son is he was a straight A prep school student with a bunch of friends. So his experience of himself is that he was a disaster, right? He was a train wreck. So he came to me when he was a teenager, he said, "Dad, can I see somebody?" I said, "Sure." So I went with him to a psychiatrist colleague who was great. I mean, the guy's great. And we were sitting in the waiting room, and we're given one of these Likert scale kind of measures, where you rate things on a 7-point scale. And so we were sitting there where I was filling out my experience of him, he was filling out his experience of himself, and we compared our notes. And so he was all 5, 6, and 7s on everything. I was all 1s and 2s. So he was catastrophizing, and I was minimizing. So you see this show up in the data. See, so that tall blue column, that's him at the beginning of treatment, right? He sees himself as really in bad shape. And me, on the other hand, I'm the minimizing parent. I say, "Hey, this seems fine to me. Everything seems to be going well, actually." So his treatment was very successful. His psychiatrist was great, and he felt a lot better having gone to see him for a period of time. And so when he did a follow-up measure, my son's description of himself was way better. Me, on the other hand, I started to understand that my son had needs that I simply hadn't realized. So when you remeasure me on my perceptions of my son, he actually is doing worse in this traditional measurement scheme. So can I have the next slide? Let's take the opposite. Have you ever seen a minimizing youth? I actually do better at school when I'm high, or, that kind of stuff, right? So I used to have an alcohol problem. Now I love the stuff, right? So um, I'm minimizing parent and a I'm minimizing youth and a catastrophizing parent. You get the opposite effects, right? So I'm minimizing youth who's denying that they have any issues. If you have an effective treatment, when you remeasure them, they get worse, right? And you've seen it. We call it the therapeutic hook. That's not what it is, frankly. It's people become aware that they have needs that they didn't realize early on, right? People say you have to get better before you get worse. No, you have to recognize what your needs are before you get better. That's really the truth of it. And a catastrophizing parent, oh my God, I was so worried about my child, and now they're getting help. They're beginning to see their issues. I feel so much better about the situation. So you see how that measures, right? In a traditional measurement scheme, the youth gets worse, the parents get better. Now so everybody sees two successful cases, right? Let's do our standard program evaluation and compare them. So here's a program, two successful cases. You look at their outcomes, you see nothing happened, nothing happened. So, but that's not true. It's because averages don't reflect performance when you have pre-triangulation measurement. So if you could go back to oh no, actually this is fine. You can go to the next slide, April. So the idea is you really have to talk to each other first to create a post-triangulation measure. And that's really the key to a communimetric approach, is that you're combining the stories, and you don't want to measure the story until you've combined all these stories, but you really want everybody to be on the same bus. You want everybody to be singing from the same choir book. You want everybody to agree, yes, this is the story. So that's the origins of communimetrics, that concept. So it's designed specifically for helping sector. There are, most of you, if not all of you, maybe not every single one of you, but most of you know the 6 key characteristics of a communimetric measure. That the items are designed to be relevant to decision making. That is fundamental to using this for decision support, right? If you have an item that's irrelevant to what you're going to do, get rid of it. You only need to have a minimum standard of understanding that informs decision making. So the action levels are also fundamental because that creates a non-arbitrary metric. So can you show the action levels? In case you don't know these, and most of you do, the 4 levels for most of the items. There are a couple of versions of different measures that have a 5 level item. The skill constructs have 5 levels, but most have 4. So need, no evidence, no need for action. 1, watchful waiting prevention. 2, action. 3, immediate or intensive action. That's relevant because a 2 is different than a 1. So that allows you to have, and ask any parent, if you have an oppositional kid and it's getting in the way of your ability to raise that child, if you move it from a 2 to a 1, that's a notable difference, or a 3 to a 2 is a notable difference. So there's differences across these levels that are real. They're real to people. They're real to the lived experience of people's lives. So the strengths, 3 is no strength has been identified. A strength is you identified it, but you need to build it. 1 is it's useful, and 0, it can be a centerpiece. So if you could go back to the 6 key characteristics. So that second dimension creates this non-arbitrary metric, which is really, really useful when you're trying to create an algorithm. About the youth, not about the person, not about the person and services, is really important. So traditional measurement makes a fatal mistake, that you can't use traditional measure to decide what you're going to do if somebody is in an artificial environment. So you can't decide level of care if you've got somebody in detention, because if you use a traditional measure, you say, well, I don't see any of these problems. They haven't run away in the last 30 days. Well, of course, they've been in detention for the 30 days, right? So they haven't tried to hurt anybody while they've been in, a psychiatric facility. So you can't use how somebody's doing to make a decision about what you need to do. You need to contextualize it in terms of what they need, not based on the context in which they're already getting services that are masking the needs. So if you don't unmask the needs and describe those needs, and not the fact that you can mask them, you will make bad decisions based on a measure. And then culture and development, if you don't consider culture and a person developmental stage, you also make that bad decisions. It's that not failing to consider culture is where systemic bias can get embedded into your decision support process. And we'll talk about that more later. About the what, not about the why, is really about creating a consensus, because it's so much easier to reach a consensus, to do the post triangulation measurement if you don't get into the why right away, if you kind of go with the what, because shame and blame's in the why, and if you stay away from the why and just establish the what, you get to consensus way quicker, and so you can actually do multiple storytellers into a single story a lot easier. And then the last 30 days is really also important, and believe it or not, this was the most controversial of these characteristics when we started doing this work. People wanted to keep it 6 months, they even wanted it a year, right? So because a service system is incentivized to make people as messed up as you can make them and keep them as messed up as possible, as long as you can possibly keep them messed up, right? That's the design of a service system. I'm not saying that's how people work. I'm saying that's how the system is designed. You know, you are incentivized to meet medical necessity criteria or whatever. And so, you know, I don't want to present people in the worst possible light so you can get paid to help them. That's a disaster for us. It's actually been one of the most fundamental problems that we've had in creating a lack of trust in the system. So you really have to be talking about how somebody's doing now if you want to make a decision about them now, right? So I have fought many people about trying to do ACEs to guide level of care. That's institutionalizing trauma. That's saying if you've ever had a trauma, we're going to treat you as if you are reacting to it as if you've never recovered from that trauma. So that's saying nobody ever recovers from a trauma. That's horrible, right? That is not the way we want to create a transformational environment. All right, next slide. So these are the grid tactics in TCOM. Most of you know this stuff, right? And so we're going to focus in on the decision support. And we're really going to focus in on the middle top cell of this grid. So the eligibility step down, that's the algorithms that can use decision support at a program level, for level of care, for program eligibility, for acuity, for service package, for EBPs, for whatever. Okay, so I am now going to turn it over to the esteemed Dr. Fernando.
Thanks, John. I want to just take a pause to see if anyone has a reflection, a comment, a question, an irritation they want to share. It's not every day you get to hear Dr. Lyons speak, so and I always tend to learn something new. So I don't know if anyone has anything they'd like to say right now. The one thing I also know, when John speaks, he packs it in so tight that it takes a couple days to have the aha moment. I have those all the time, and he knows because I text him. I'm like, oh, I just understood what you just said. So if you're still unpacking, I totally get it, and I'm gonna start talking here, and maybe you will.
Can I explain why I do that to folks? Because the research suggests that you have to say the same thing multiple times for people to hear it, but there's no research on how fast you say it. So I just do the fire hose, because I figure you throw everything on the wall, and so it's going to stick, and so it's not going to stick. So. Oh, yes,
All right.
I've tried to update I try to keep contemporary with my jokes. I'm not always successful because I am an old man.
All right, so let's talk more about, I'm going to go backwards just a second. Let's talk more about this part, the decision support part. I think most of us here today are pretty comfortable with this column and how we can use Communimetric tools in this column, but let's talk about this particular cell in this table for just a minute. So most of us are human service professionals that make decisions every day when we go to work, multiple decisions a day. And our decisions are initially based on our training, training for our job, training for our discipline, our profession. And that training gets tempered over time by practice experience. And if there's ever a good teacher, it's experience, right? And sometimes the most impactful way to learn is through experience. But what we don't factor into our learning through experiences are the things that we learn sort of unconsciously or otherwise, sometimes consciously, that form into biases that are reinforced by the decisions we make. John talked about this already earlier. So decision support refers to using information to decide what is going to happen next. Okay, and the communimetric data is decision support information. That's the information we're going to use to help us determine what happens next. And because the CANs, the ANSA, the FAST are person-centered tools, the communimetric information is about the people, and that's the information we're going to use to help us develop models on how we can think about decision support on a program or a system level. So we're going to walk through how we can do this with the CANs and ANSA and FAST with you this afternoon. Okay, so Communimetrics is being used effectively across the country in child welfare settings and in behavioral health settings across the US to make several types of decision models, okay? And so you can see here placement type and intensity. New Jersey's pretty familiar with that. Level of care. So Indiana, there's a lot of level of care decision support algorithms out there. Case management intensity, case rates. Wisconsin is and Indiana are the leaders, but we're getting more and more requests for case rate algorithms. Service packages, evidence-based treatments using the CANs, the ANSA to help understand which patterns of needs would be best served with certain evidence-based treatments. And also we have some mini algorithms that help us determine safety and risk at the front end of some child welfare systems. For example, Tennessee, South Carolina have algorithms like that. Okay, here's a map that we've recently updated. So the blue tells you where the CANs is being used statewide. The green tells you where it's being used, at least in some counties, and the yellow represents the CANs. This is a CANs focused one being used in at least organizations. The gold stars are where we've got algorithms running. Some of them have been running for more than 10 years. Some of them are less than that. And then the stars, the outlines, are where we are currently developing or testing algorithms. They're not yet being used in those states. So just to give you a sense of the scope of where we're developing algorithms. And as John said earlier, the Families First QRTP designation has been keeping our phones busy. People are calling us to help, they want to know if they can use the CANs. Because of the language in Families First, there needs to be a child and adolescent assessment of needs and strengths. It sounds like the CANs, so people Google the CANs and they find us. So we've been answering a lot of questions about the CANs and QRTP. So when we're looking at person-centered decision support, as John hinted to earlier, a lot of the tools that are used to help determine level of care, for example, use service receipt or service history to inform the level of care. And while that sounds like a good idea, right, you have to think about the fact that the decision of who gets what type of service may not always be because of perfect clinical and comprehensive clinical thinking. There could be other reasons, those determinations for being hospitalized for psychiatric reasons, being put on medications. There could be other reasons that were influencing those decisions. So because of that, we tend not to use service receipt as part of our decision models because things like racial inequity, cultural factors, even availability, right? There are some places in states and counties that are, Tim Haugen can tell you, there's some parts of his county, because he's got a big county, where they don't have as much services programs available as they do in San Bernardino, for example. So he might have to place someone in a higher level of care because there's nothing else available for that young person, right? So availability can impact decisions. That's not necessarily the best clinical decision. It might be the only decision one can make. So we want to make sure that we understand that history of services or service receipt may not be the best metric to put into a decision model because it might be fraught with all kinds of problems, right? Compliance is often, I forget which tool has a bunch of compliance questions. John, can you remind me?
It's the locus, the cal locus, the CASI. So
yeah. So compliance is also, right, akin to service receipt, right? Prior service receipt. So again, we try to not have those as part of our decision model algorithms. John, you want to take over from here?
well, I thought you were going to do this slide. So,
oh, I can.
yeah,
So this
I'll
slide
just, yeah.
comes from the Hayward Burns Institute. So we are acknowledging that they put this together. It's a little bit dated, but I think it provides the it highlights the points that I'm trying to make about how sometimes the tools we use or the information we're gathering doesn't necessarily have the outcomes we want for the kids that are in our systems. And it tends to really impact the kids of color and the indigenous kids in our systems.
So this is why I think that we've come to the conclusion that it's so important to not use service receipt, not use compliance indicators to make decisions about level of care, intensity of services, because it does. I mean, if non-compliance were strictly a function of the person being helped, that might make sense. But it also could be a representation of cultural incongruence between the type of help and the person's culture. So given all of our disparities in the system, to make decisions based on that, which is the standard, frankly, for people who don't use the CANS and ANSA and FAST approach, the standard is to use either compliance or so a third of the measure of the metric on oh, April, they're asking who created the slide. A third of the measure on the locus, the cal locus, and the CASI are compliance indicators. So we think it's a problem. I personally, I love the levels on cal locus and locus. I think they actually do a nice job of defining the levels, but I'm really troubled by an emphasis on compliance, because if people don't do what you tell them to do, that's not necessarily a reflection on them. It might also be a reflection on us who are telling them what to do. So I'll go to the next slide. And just to make this point, so this comes from a long time ago. And this is when I used to run the the mobile crisis programs monitoring for the state of Illinois. It's called SAS. And we implemented the very first version of the CANS. It was called the CSPI as a decision support. And we didn't tell people what to do. We just gave them feedback. So we created, you can take the CSPI and create 7 items that do a good job of predicting whether or not somebody needs to be in the hospital. It's actually quite a valid indicator of that, and actually predicts hospital outcomes. And we just gave people feedback. And over time, as you gave people feedback and just asked them, they had to respond to it. They'd say, you know, we'd say, you hospitalized Mary, most people wouldn't hospitalize her. What happened here? Or you didn't hospitalize Johnny, most people would have hospitalized Johnny. What were you able to do that led you not to be able to hospitalize Johnny? We just did that. And what you see over time is the reduction, near elimination of racial disparities in hospital decision-making just by paying attention to, are people following the algorithm without forcing them to follow the algorithm. It wasn't mandated, it was just used as a CQI kind of approach. Now, we were finding that a large number of kids, particularly kids in the minority, were being hospitalized low risk, over 20%. And that's when I ended up getting fired from this project, because the psychiatrist actually in the state didn't want me giving this information back, because they wanted control of that decision making. So, c'est la vie. Again, the system isn't always about the best interests of the people we serve. So, next slide.
So just to reiterate something John said earlier when he was talking about IQ, and here is the example, right? When we use total scores with cutoffs, we have problems making decisions at the margins. And so John talked through the problem between a 69 and a 70 on an IQ score. He also talked through the problem with the Beck depression inventory. And those of you that use that tool a lot, like I used to, you know that 20 to 28 on the Beck depression inventory says you've got moderate depression. But then 29 to 63 says you've got severe depression. So what's the difference between 28 and 29, right? I mean, if you think about moderate versus severe and the interventions you would put into place, that's a huge difference, right? But then if you think about 28 and 29, you're wondering, am I making the right decision? So the problems at the margins are real problems, and they really impact the way that we decide how we are going to pursue treatment for people. So the approach, the communimetric approach, is actually to use Boolean or branching logic models, or patterns, if you don't speak statistics, patterns of needs and of actionable needs. Okay, so here's an example, because we use this language of and or, and John says there are some algorithms that have not. And I thought we need to be cheered up with talking about puppies and kittens. So if you look at this graphic in the middle here, right? If we're talking about and, we're talking about both puppies and kittens. If we're talking about or, it's either puppies or kittens. And if it's not, in this case, it's puppies. This is a dog skewed algorithm, whatever. But it gives you an idea of how we use patterns of needs, actionable items, the 2s and 3s. You're going to see that in an example I'm going to give you later as to how we put the algorithms together. The nice thing about this, which is why I'm talking about this part of it, is that these models are very understandable from a clinical perspective. In fact, when we create the algorithms, we start with how are decisions being made from a clinical perspective, because we want the algorithms to reflect that clinical thinking, but focused on the actual needs of children, rather than what the system sort of is trying to say is important. It's about what's going on with the children. So the communimetric algorithms are decision-making as a consensus process. So we haven't moved away from our roots in TCOM. In fact, we're operationalizing TCOM in this process of decision-making at the program and at the system level. So I'm going to walk through how an algorithm is actually developed, unless, John, you have something to say before I go there.
Nope, I'm good.
Okay. All right, so here we have pieces of a puzzle.
Oh, actually, no, I would like to say one thing. So, which is,
Sure.
So one of the things that people worry about with any decision support for anything that has money tied to it is people will fake it so that they, that they'll lie basically to get money, right? So that's always a factor. And we have a sad history in the helping professions of that being a reality. So we think consensus and transparency and multiple use is the fundamental to addressing that. Anybody doing anything by themselves, in a room that just does it and then gets paid and not paid is subject to those pressures. But if you do it in the open and you do it with others and you do it with the people you're trying to help and other people and so forth, if you do it in an open, transparent process, and if it matters, then we think that helps keep it honest. And if you use these measures for a bunch of different things, that also helps keep it honest. So I do think we should talk about the elephant in the room, and consensus is really a fundamental for that piece. So
John, I just want to mention the question from Daniel about, is there broad agreement on the differences between the action levels on the cans? And you did answer him, but I wondered if you might want to say a little bit more for everyone to hear.
yeah, so I think, the ecological fallacy, of course, is you have reliability of a metric, but that doesn't mean everybody's reliable, right? So you do get differences across people. Again, it's the same deal, that the more you make it as a consensus, the more people you involve in the decision making, the more transparent it is, the better clear differences between a 3 and a 2 and a 1 and a 0. So research is clear that the items are reliable on their own, but that doesn't mean they're always completed by everybody reliably on their own. And we do think the more you keep it as a consensus process, the more people learn from each other to use it in a common framework. So,
which is the other reason why we require certification on the tool annually, right? To make sure people understand the items, understand how to apply the action levels. All right. Any other questions, thoughts, reflections before I move on? All right. So like I was saying, these are, when we're trying to understand people, we're trying to usually put pieces of a puzzle together to try to understand people. And so when we're making decisions about groups of people, we're trying to do the same thing. And so the C here stands for criterion. So there might be 6 different criterion we're trying to determine. We're trying to think about when we're trying to determine if someone fits in a particular level of care. So the example I'm going to give you is for treatment foster care. Okay. And so I want you to think about this through an example. It might not be the best example, but it's an example. So let's say we've got 2 kids. They're both 11-year-old boys. They were both adopted by different families, living in adopted families. And the parents describe them like this, right? These boys have experienced trauma of losing their birth parents. We don't know how, but they lost their birth parents. Both boys have challenges at school, right? They get calls from the school almost every day. Both sets of parents feel like the boys are overwhelming. They take up a lot of time to the degree where they're worried that they're neglecting the other children because these boys take up all of their time. Okay, separate homes, separate boys. They're both 11. They both happen to be adopted, but this is the story. So let's see if either of these boys fit for treatment foster care. So one of the first things we try to understand is, when we are developing an algorithm, is, there we go. Let's identify that there's a treatment need for this young person. We need something to treat, okay? Which is good news for the behavioral health people in the room, because you need to establish medical necessity, right? So we've got 3 criteria here that will help us determine if there's something to treat. The first one is at least an actionable item on a behavioral health need. So anything from the behavioral emotional needs. Okay. Another criteria is at least a 2 or 3 on developmental intellectual as an item. And then the third criteria is we have a 2 or 3, an actionable rating, again, on the medical physical. So these 3 pieces make up the treatment need. Okay, so let me tell you about the first boy. The first boy is spacey, dissociative at school, doesn't get his work done. And whenever he's got male teachers, he gets way more spacey and dissociative. He just stares out the window. So he's got an adjustment to trauma at 2. Okay, because he's failing. The other boy, he's like all over the place. He's impulsive. He's hard to settle in class. And they're not quite sure what's going on with him. He's got sickle cell, right? He's got sickle cell that's not being managed properly. He's spending a lot of time in the hospital because they can't manage his sickle cell at home. And they've got a lot of doctors involved with them. Okay. So one boy has got, so the boy I just talked about, he's got impulsivity, he's got a 2, right? So he's got a behavioral emotional need. He's also got a medical physical need. The other boy has a behavioral emotional need. He's got an adjustment to trauma need. Okay, with me so far? So we've got treatment needs we've established for both of these boys, but we need something more because at this point, it might be that we could treat both of them in outpatient settings. Okay, but let's hear more about the kid with sickle cell, right? So not only has he been in and out of the hospital, he's recently started having seizures that they can't seem to control with medication, right? And now he's got a lot more doctors involved with him, not just to help him, but try to help the parents manage him at home. And it doesn't seem to be working very well. So now you're hearing why the parents feel overwhelmed and it's taking over, right, most of their time, and they're worried that they might be neglecting their other kids. So that's kid number 2. Kid number 1, he's got problems with his family. He's got friends, but he's having problems at school because basically he's dissociating and he's getting triggered at school. That's what's going on with him. Okay, so let's see with the rest of the criteria where these boys fit, right? We're looking now at complexity. Okay, so the first criteria is at least a 2 or 3 on these particular life functioning needs: family functioning, living situation, social functioning, or school attendance. Okay, our first boy who's got adjustment to trauma, he doesn't have school attendance issues, he's got school achievement issues, right? And maybe it's because of the adjustment to trauma. We don't know if he might have a learning challenge. It's hard to say from the little bit I told you. Okay. Another criteria here is a 2 or 3 on any of these particular items in the medical module. Those of you from New York are very familiar with this module. Okay, so impact on functioning of the medical condition, life threat, and organizational complexity. And you can hear all of that in the second boy that I described. Okay, and the last one is a 2 or 3 on the following risk behaviors: suicide, self-injurious behavior, other self-harm, danger to others, runaway, delinquent behavior. We didn't hear any of that from either of these boys. Okay, so these 3 in pink are what's going to help us determine complexity. So for this particular treatment foster care algorithm, you have to meet one of the yellow puzzle pieces, C1, C2, or C3, just one. And you have to meet one of the pink puzzle pieces, C4, C5, or C6. Just one. Okay, so remember the puppies and the kittens, we've got an and here. We've got in the or also. So we need one from the first group. We need a treatment a treatment need we can identify, and we need to show some complexity. And in this case, the second boy with sickle cell is probably the one that we might consider for treatment foster care, right? It's a decision support, not a decision-making algorithm. So we want to talk about it clinically to make sure that makes sense. All right. John, you want to take over from here? You're muted.
Did you want to talk about the two young men? What did you decide on each one?
Oh, I decided that the second one with sickle cell
Okay,
would probably benefit
sorry, I
from
missed that. So
treatment.
yeah,
foster
because he
care,
needs
yeah.
a more structured environment to take care of his medical needs, because it's
Yeah,
becomes dangerous at some point not to address those needs. Or is it?
right.
Very good. Okay. So next slide. So there are some off-the-shelf decision models. We don't think that's a very good idea because every place that we've been is different. And you know, sometimes you have different services that, I mean, what's interesting for us is the people we serve are the same everywhere. Kids are the same kids everywhere. But the systems are quite different. You know, adults with behavioral health needs are the same everywhere, but the systems are different. And using an algorithm to guide system change is not all that different than a therapeutic process. That you can't just come in and say, this is the way it is, we're laying down the law, and from this point on, you're doing it this way. That doesn't work very well, because you kind of have to start where people are so that you can help them evolve to where you want them to be. So we do think that since different systems are different in their offerings and in their current status, that you really need to customize your decision-making approaches to make sure you're doing it in a way that's culturally appropriate for that particular setting. So to give you simple examples, if you're doing a QRTP kind of model, if you have in a particular state or even in regions of the state, well-developed intensive community care, you can actually serve more complex kids in the community than if you don't have a well-developed intensive community care. So if you're in a state which really hasn't had the ability to develop your wraparound and other forms of intensive case management, intensive community interventions, then you actually have to be careful, because you don't want to be underserving people, because that's actually bad outcomes when you underserve. And so you'd have a lower threshold into a QRTP if you don't have viable community options than if you do. So what's happened, of course, is that states have been doing this for a while. You can begin to tighten up your algorithm so that you're actually placing more and more complex kids out of community as you gear up, as you beef up, as you develop your community capacity. And New Jersey is a great example, but there's a bunch of states that have done a good job of tightening up criteria for placement. So if you go into certain parts of the US, very few kids are placed in residential treatment because they have these options in the community, where in other places, it would actually be a disservice to not place them because you don't have those other options. So that's why you have to contextualize that. So, you know, the very first algorithm we ever did was in Illinois. It resulted in it was for residential treatment. It resulted in a 30% reduction in the number of kids who are in congregate care. And all it was is you had to have something to treat, and you had to have a risk behavior. So it was actually the treatment foster care algorithm that April just showed you. And that algorithm, actually that algorithm, nobody in the country uses an algorithm that low now. That algorithm resulted in a 30% reduction. We went to a different jurisdiction, and that jurisdiction had 2/3 of every single child in their system was in congregate care. We had to have an even lower threshold for them, because you could not just simply move all those kids all at once, right? So you have to kind of make sure you're fitting it where your system functions. Whereas now you look at a state that has sophisticated intensive community services, the algorithm for residential treatment is multiple threes, you know, 2 or more threes on the behavioral health, or 3 or more 2s or 3s, and 2 or more 3s on the risk behavior, or 3 or more 2s or 3s, right? So that's a very high level. So you want to make sure you're doing it in a way that's culturally congruent. I have the next line. So there's a bunch of places. We thought we'd walk through some data. Are there any questions before we get into that? Did I show you some? There's nothing like seeing charts and graphs at the end of the day.
Let me
Wait,
stop
Caleb,
sharing for a second and so that we can look at folks and then
okay,
answer,
right.
see if
So
there are any
check in.
questions. Yeah. I
Did you
think
have a question, Kim?
Yeah, I was just
No problem.
thinking that when you early on and being around for 17 out of the 20 years in the system of care, showing the data, especially with the community residents, the PCRs, and showing how the Kansas data, they were actually getting worse, and then the restructuring of our system to have more therapeutic foster care, and so this all makes a lot of sense, and I love the fact that you're not taking algorithms, even though people say, can you give me a set that I can use across the board? I'm not going to say which state, New Jersey, but in terms of making sure that there's a continuous loop with real-time data. So I want to say thank you. That's all. Thank you.
Yeah, I think that also brings up the idea. Now, April said it, but just to highlight it, we don't see these things as expert systems. We see these as decision supports, right? You don't want an algorithm it's not artificial intelligence. It's raising the level of conversation, providing some common structure to how people think about it, but still giving them freedom to override it or whatever, depending on the specific circumstances. So that's why we're very careful to always use the term decision support. It's not the decision itself, it supports the decision, and sometimes other factors are involved. So, other comments, questions, observations? The other thing that New Jersey did that was, I think, extremely clever and probably, and I'll hold that story until we show the data, because we have some New Jersey data just for you, Ken. Show you what a stellar job you've been doing over the last 17 years.
The system has. I've only tagged along.
All right. Well, that's true.
Imagine the question is, does this work, John?
Yes. The question is, does it work, right? So that's the question. Well, the answer is yeah. I mean, it always strikes me as kind of a duh, right? I mean, we all know that all sorts of stuff other than the best interests of kids and the best interests of the people we serve influences what happens to them. So if you just kind of create a structure that reminds us that we should be making our decisions about the best interests of people, that's going to have an impact. Subtle, but I think the evidence suggests relatively profound. So interesting, there's an economist at the University of Maryland that just did an analysis for a conference paper. He's now writing it up for publication that demonstrated just the very act of implementing the cans in a state. So he looked at all the states across the country. He looked at the date of implementation of the cans, that just implementing the cans in any statewide sector was associated with a 3% reduction in the number of kids who went into child welfare. Now that's an interesting statistic, right? So it just means if a state kind of commits to trying to do person-centered care, it has implications for what happens to kids. I don't think that's the cans per se. I think that's just people trying to figure out how do we make decisions based on the best interest of the people we serve. And when you do that, when you start to create systems that do that, you have, I don't think it's surprising at all, you have better functioning systems, because it's all the other shit that gets in the way of good decision making that makes for bad systems. It's when things like that shouldn't influence the decisions, like money or culture or color of people's skin, and when those kind of things factor in, that's when you have bad outcomes. So anyway, I believe that firmly, but that, and we'll show you some data. So I think that's the next section is, okay, back it up, Lyons. So, okay, so the next slide. So there's a bunch of places that have been doing it a long time. So here's New Jersey. You've heard me say it. I think probably many of you that I think New Jersey is arguably has the best children's system of care in the country. And I'll show you the data to support that. So here is the number of kids over time. This is from the presentation by, I'm having a scene, Elizabeth Manley's presentation at the Princeton TCOM Conference. So as you can see over time, by having this non-means tested system of care, New Jersey expanded the number of kids in care almost threefold. right? They almost tripled the number of kids in care. Now, the next slide is the interesting one. So, and this is the impact on the number. This is the actual number of kids sent out of community. So although they're tripling the number of kids in the system, they actually had a 1/3 reduction in the number of kids who were placed out of community. So that's pretty substantial. That's pretty stunningly effective. At the same time, they reduced the number of detention centers by 1/3, and they closed their psychiatric hospital for kids. So arguably the best children's system of care. But I want to make a point. See that inflection point where you see it's kind of steady and then you see a sudden decline? This is around the time that they used their data actually to, so the way it was originally structured was that they had these 3 levels of care. They had nothing. They had this thing called youth case management, and then they had a thing called the CMOs, case management, which was designed to be a wraparound kind of program. So the CMO was designed, and the coaches for the CMOs were, folks from Wraparound Milwaukee and so forth, really good people who taught folks in New Jersey how to think about working within a wraparound framework. But as you may know, wraparound program is an oxymoron, right? You can't actually have a wraparound program because a program has a beginning, middle, and end, right? And there are slots in a program, but wraparound is doing whatever it is you need to do, right? So what was happening is you only got a certain range of types of help if you're in the CMO, if you're in the wraparound program. So the challenge is the level of needs of people, of families and kids going into wraparound is pretty complex. And those families never actually eliminate all their needs. And so a wraparound program creates this untenable moral, ethical, clinical decision that you've had enough when nobody's really ever had enough. So there are people who are they're being held in the wraparound program because they still needed respite. That's all they really needed. But the only time you're eligible to get that would be if you're in the program. Yes, residential treatment referred to congregate care. That's true. So that's a problem, right? So what was happening is there's kids over time, over the first few years of the initiative, kids who would have otherwise been eligible for wraparound, for the CMO, were getting stuck in the youth case management because all the slots, because we were thinking about it as a program, all the slots for the CMOs were filled. And it was very hard to have a back door on that. So they actually moved to unified case management. They got rid of their wraparound program because wraparound's a philosophy. You do whatever you need to do. So they created a unified case management approach. And so they didn't have this artificial demarcation that you only got certain things if you're in a program versus not in a program, and you got what you needed within that. And that, you see, is when around there is when you start to see the real impact of doing that kind of intensive community service that's based on the needs of kids and families. So that's New Jersey. So the next slide. So here's, this is the origins of it. So I actually alluded to that before, this one before. So we had actually the original CANS algorithm was here. It was actually done with the CSBI. There's a body of research done by Brian Shore. I don't know if Brian's in this meeting. He is probably the most published guy on CANS algorithms. So you might want to chat with him. He's at Chapin Hall at the University of Chicago. Kind of good guy. So he's looked at a number of different things. I think what we have here is the data. So it was embedded in a SAYET here. So this actually demonstrates, this is a survival analysis. This is one of the foundations of effective child welfare is stable placements, and there's a lot of instability of placements in Illinois. So these are 3 survival curves. So the green line is when people followed the CANS algorithm. So you had the most stable placements. The blue line was when people were overserved. They were served at a higher level of care than was recommended by the algorithm. And the brown line is when they were served at a lower level of care than recommended. So you can see underserving is actually worse than overserving, but properly serving is the best. So, and of course, these are huge samples. This is like over 10,000 kids. So all differences are statistically significant if that's a meaningful construct at all anymore. So, all right. Everybody clear on that? That's a little bit obtuse, but so basically, if you follow the CAN's recommendation, you end up with more stable placements. The other thing that happens, of course, yes, that is true. Amanda is exactly right. Okay, next slide. So here's Tennessee. So this is done by Richard Epstein and Mike Cole when they're at Vanderbilt. This basically shows exactly the same thing. So Vanderbilt, they implemented the CANs and they got themselves, and a part of it, I mean, they did a bunch of other things. They got themselves out of a lawsuit with this approach because the CANs was part of the solution to the lawsuit. So this is just demonstrating that if you follow the CANs recommendation for level of care, I think they had 4 levels in their model, you had more stable placements. So it just replicates the Illinois data. Next slide. All right, so this is the CAN. We haven't done as much research on the ANSA. For those of you who are ANSA states, we would love to work with you on that to do the same thing. Again, I would be quite optimistic. But one of the things we are doing is trying to do a research on these approaches and implicit bias. And we do think that a person-centered approach is likely to have less problems with disproportionality and disparities, but that's an empirical question that we really have to answer. So I'll turn it back over to you, April.
All right, so some people often ask us, how do we create these? Can we make these ourselves? Can you just give us the copy of the New Jersey algorithm? Because it seems like it's pretty cool. Let's just use that. I think John described why we don't recommend that you just take someone else's algorithm and implement it, because we do customize them for the particular situation of the jurisdiction, to make sure that we're starting where the jurisdiction is at so that the algorithm optimizes what they have to offer and can grow with the system as well. Here's kind of the process that we go through with jurisdictions to help them develop algorithms. We do like to be aware of algorithms being developed. John didn't say this, he often does, but we've been a solution to a lawsuit. We haven't had a lawsuit yet, and don't plan to, around the algorithms, but it is one of the areas that is the most sensitive in our work because it impacts, how people are provided support. And so we do like to know if people are developing algorithms, and if we can support that process, we would be happy to. But this is the process in which we develop algorithms. So like I said earlier, we do want to understand how it is that you're seeing the different levels, whether it's service intensity or level of care, how you are seeing that in your system, how you make those decisions now in your system. And then we will map the CANs, the ANSA, whatever tool you're using to that decision model that you have. And it'll look something like the puzzle pieces I showed you, not quite in that visual way, but it's basically we set up a pattern of the criterion for each of the levels that are based on the pattern of needs, typically for the children or the adults. Sometimes we also use caregivers with the child-driven, the CANS-driven algorithms. We do test them. We do a clinical sniff test, as I like to call it now, and we also do some data testing on the algorithms, tweaking it as we go along to make sure that it makes sense before we actually recommend it being launched. Any questions? John, did you want to talk about this?
Yeah, basically it's a reverse engineering approach. So we start with what your decisions are and then work backwards. We try and do it clinically first, because again, you want to be able to put into words how each group is different. So this particular analysis is done by Stephen Shimshak and the Precision Analytics team. So this is one of the tests. So Tim just asked about how to test them. So this is the first test, is April referred to it as the smell test. So what that involves is just having some experienced clinicians to run some cases, some kids, some adults through them, ones they know, or maybe. And so kind of, does this make sense? Or if there's, problematic situations, it's oftentimes a great place to start. Is you have a problem, you have somebody you're struggling with, is run those kind of folks and just see how it feels, how it fits. That's a smell test. It's not empirical. It's just a case study, a case series, if you will. But it's a good way of identifying problems, because you will say, oh, wait a minute, no, this is leading me down the wrong pathway on this particular situation. So it's helpful. The next step is more empirical. So this is the first version of this. This is internal to the process. So this particular slide shows so this is 3 levels of acuity. So this is from an acuity algorithm, where you have high, medium, low for case management intensity. And it's the total number of actionable needs by the levels. And so you can see in that first thing where you're using the algorithm variables, you see a really clear separation between the 3 levels, and say, okay, so look at that, the pink, the high acuity group is pretty distinct. They have a lot going on. So this is why they're high, right? And so the medium is in between, and there's not a lot of overlap. There's more overlap between the low and the medium than there is between the high and the medium, or the high and the low. And we use this because what we can do is look at what are the items that are on the algorithm that aren't distinguishing these groups, and what are the items that are. So that actually helps us refine them, because you want to get some reasonable separation. That's pretty good separation. The slide on the right, so that was the slide on the left, is the one that has only the items that are included in the algorithm, and it's the total number of them. So it just gives you a sense of just how complex is the case. So we call the total number of actual needs a complexity index, because it's how many different things are you worried about at the same time. So that's complexity. And our experience is that complexity drives intensity. Severity doesn't drive intensity. Complexity drives intensity. So the next the slide on the right, the graph on the right, is just everything. That's taking everything from the can to the ant. So all the actual needs, all the 2s and 3s, whether they're in the algorithm or not, you just include them. So for instance, the algorithm that April showed you for treatment foster care, it had school attendance, but it didn't have school achievement or school behavior, because that's not really a treatment foster care. The parents are not responsible for the child's behavior at school, and they're not responsible for their achievement skill. That's a special education need. It's not a treatment foster care, but the parents are responsible to making sure that child goes to school. So that actually would be a thing. So school attendance in that model would fit on the actual needs on the left, and school achievement and behavior and attendance would fit on the right. So you'd expect less of a separation, but you still want to see a separation. You want to see the peaks different from each other. You see that, but you do see some overlap. This second set of graphs allows you to identify items that are not included in the algorithm that actually make a distinction between them. So you can see there's here in this particular algorithm, there's more of a gray area between the low and the medium than the high. The high seems to be pretty clearly defining a high group. Although there's a couple people, some kids in the high group that actually don't have a lot going on. Those kids, this is a health home algorithm. So those kids are medically fragile kids, where they have a few things and they don't have a whole lot of stuff. Behavioral health kids tend to have a whole lot of stuff going on. Medically fragile kids sometimes just have both a complexity and a medical need, and it just goes higher need faster. All right. After that, the next thing we need to do, Tim, is you actually collect some data. And so you want to do a couple things with it. Ideally what you want, and usually it's not possible to start with. But what you'd like is a panel of cases where you have the CANSA or the ANSA or the FAST, and you can follow them some period of time. You follow the algorithm and you look at the impact, whether following that's the ideal way to do it. Typically, people are doing this, don't have a mature enough data set for the start. And so what we tend to do is test it by, again, it's more of a qualitative case series analysis, in the sense that you take a panel of 100, 200, 300 kids, and you run it through the algorithm and you see where they fit or don't fit, and then you identify the non-fits and take a closer look at them, typically with more of a case review model. So for instance, we just did this with an unnamed state, which I happen to be in at the moment. So and in that analysis, what we found is that the kids were being overplaced. So in other words, they're ending up in congregate care, in residential treatment, when probably, according to the CANS, you wouldn't recommend it. There was a couple of different groups, actually. You could kind of see 3 different groups. You could see one group of obnoxious kids. I mean, they weren't dangerous. They were just really tough to deal with. A lot of oppositionality. They're older teenagers who were oppositional. They weren't doing dangerous stuff, but they weren't very easy to live with. And so adolescents are hard to place in the first place. And so those kids ended up going into group homes, congregate care kind of facilities, because there's no place else for them to be. They didn't really need that level of care. It's just they couldn't find willing foster parents for them. Another group was kids who had, there was a group of adolescent girls who were sexually acting out. They were promiscuous, I suppose would be the old term. They were sexually acting out. It's a little unclear. Some of it was trauma, some of it maybe not. Maybe it was all trauma. It's a little hard to tell. But they really weren't dangerous. They were just, we never saw any young men who were sexually acting out who were overplaced, but we did see young women who were overplaced or sexually acting out. So we're not quite sure what that is, whether that's a gender bias or what, but there was that group. And the third was, kids who had trauma experiences, but weren't really manifesting trauma sequela. And so it was like they were being institutionalized for their trauma experiences rather than for their actual needs at the moment. So you can use that kind of way of looking at the cases to do a more kind of a grouping of it. You can do it formally with a latent class analysis, which Stephen's group has done quite a bit of, and so forth. But that's how we end up testing it. Ultimately, you want to do something like Brian Shore did, where you're looking at long-term outcomes so that you can see. And we think ultimately we're going to be able, and this is one of the reasons why we're working to build the data reservoir, is we think that you can begin to use machine learning kinds of methods to identify, to better refine how you think about which kids benefit from what levels of care, what types of services, and so forth. But in order to do that, that requires a large amount of information from a lot of different people over a significant period of time. So we're building towards that. I think that's the future, but I think that future is probably 5 years off, so maybe less. So does that answer your question, Tim?
We're at the end of our PowerPoint, so I'm just going to open it up to questions. We've got a good chunk of time. So questions, reflections.
I did ask about New Jersey, since we implemented the CANS 2.0, I think 4 years ago, I want to say November. Has the algorithm been updated for New Jersey yet?
I don't know. If it hasn't been done collaboratively with us. I'll check.
Okay.
That's a good question.
That's what usually happens sometimes, where systems being we're celebrating 2021, our 20th anniversary. Sometimes and I'm just speaking from my own set of eyes, is that we've established something, therefore we don't need to do anything else. And I loved it where both John and April came in to do virtual town halls for us. Is if we're not moving forward, we're going backwards. And so this is a true honor to continue to learn. And so there's no algorithms that have been, because they need to partner. And I think that's the C in TCOM, the collaborative. That was supposed to be a joke too. But
Well, resting on your laurels is also sitting on your ass, right? So,
yes, I've seen how COVID has impacted that aspect of.
Well, and I also feel like we had moved away from using the algorithms sometime before the CANS 2.0, because then they developed the clinical criteria, which sort of takes into account some of the CANs, but not all of it. So I would love to see us get back to more algorithm with maybe, some recognition of the clinical criteria, some of those criteria sort of being you're not on the Boolean thing, you're this or that, and maybe not this or whatever to sort of trump things, that you were talking about. But that's just my wish list.
I know I have a series of meetings coming up in December with leadership in New Jersey. I think that's one of the topics, is to talk about those kind of things. So.
Yay.
Hey, John, this is Tony. I have a question. You mentioned about kind of machine learning as a wave of the future kind of approach, and you mentioned some of the LCA work. I'm really curious how, or if you all have any experience using those more data-driven approaches compared to kind of the clinical approach of designing algorithms around what those decision processes are already like, and how would you kind of navigate, any discrepancies between, a data-driven approach versus.
That is a fundamental question, and we are very intentional of making our current approach very, very clinical, because we are, I think, fair to say, April, we're skeptical about a strictly empirical approach. We're not sure we ever want to. I think until we actually see how it works, though, it's really hard to say no until we actually look at it, right? So, but for instance, we're extremely hesitant to do any predictive modeling with the CANs. We could do, with the answer to the CANs, the FAST, we could do predictive modeling. We could do predictive analytics. But the problem with that is it runs the risk of institutionalizing things, because you're actually labeling people about their, it's like Minority Report, that movie, you're labeling people about their future without giving them a chance to have an opportunity to affect their future. So we're a little bit concerned with the moral and ethical implications of that kind of work. And we feel the same about the machine learning. It's powerful, it's important, it's important to look at it, but I think we have to approach it with a great deal of skepticism because of the inherent risks of having something that's too machine driven. We don't believe that artificial intelligence, and we have actually people now on our team that are expert in artificial intelligence and machine learning models, and they're equally skeptical, actually. So, and we think that's important, that you just have to be careful with those kind of things, because the nuance is lost. And there's, the big problem would be, for those of you who are more statistically oriented, is sample specific covariation is the enemy of meaningful predictive models. So, you can easily predict the number of murders in the city, and one of the predictors is the number of churches. So does that mean churches cause murder? No, it's an underlying construct is population. Just like the underlying construct of race might be poverty, but poverty might be underlying race, right? And so it becomes challenging to kind of untangle the threads. And when you're throwing everything into a big model, it doesn't necessarily do a really good job of that. Now, that being said, the pieces of machine learning that we think offer the most promise are the random forest kinds of models that take you down different groupings of people based on which items separate groups, and then you kind of follow it because you actually can begin to see people's stories elaborated in those kinds of statistics. And so we think that kind of model is actually probably the direction that would be most comfortable and most likely to be ethically and morally congruent with a TCOM lens. So
I actually,
go ahead.
This is Kate Cordell. I was just going to say that a success-focused approach with a reinforcement addition to the model is also a new tool in the tool belt. So if you've read Kathy O'Neill's Weapons of Mass Destruction, she alludes to the fact that the models that have been so destructive are the ones that predict negative outcomes and don't look at how well their predictions did. But if we create models that are success-focused, so predicting who could succeed and how we helped them succeed. So even the toughest, most complex circumstances, if there was success at times, what was it that changed? What supports were given? What services were provided? What help was there that helped that person or that family or that group of people succeed? If we learn from that in those models and reinforce those decisions about how we achieve success, then AI can help us improve the way we care rather than predict who's going to fail in our systems.
Agreed completely. That's the whole notion that the justice equivalent of that is having a citizenogenic perspective rather than a criminogenic perspective. It's not about why people decide to commit crimes. It's why they might choose not to commit crimes. And I think what you're going to see when we start doing this modeling is our entire notion of what we should be doing changes. Because I think what you're going to discover is it's really about building strengths. And that if you really want people to be successful, it's about building strengths. It has actually, my guess is, what we're going to learn is it's not really about addressing needs, because people learn to live with their needs, and people can thrive even when they have needs, right? There's a lot of people. So, the vast majority of people with serious mental illness lead full lives in the community. They're married, they work, they have full lives, right? How is that different than the small percent that end up homeless with comorbid substance abuse and living on the streets? So what's the difference, right? So I think that success focus, you're absolutely, was that Kate speaking?
Yeah, that's Kate.
Okay.
Yep.
Okay, I was trying to sort through the thing and find the little yellow square, and I couldn't find you. But anyway, so yeah, so you're absolutely right. So having that focus, I think, is probably our best hope to not go down the rabbit hole of replicating problems of the past.
And I just wanted to say that you put in different covariates in those models than you do when you're predicting recidivism. You put in to those models because you're specifically looking for what led to success. And so what you're putting in there are looking at how did we achieve success. We're not trying to predict failure. So it's a completely different model. And then it's reinforced by how well that model predicted. You put in when this support was added, when this service was added, that reinforces the model to identify, did that support or service help make a difference in that situation? So anyway, thanks.
I look forward to your good work on that, but I promise to remain skeptical. So, but I think that's really, you're absolutely right. That's the pathway.
I will convert you. I will convert you. I will convert you.
Fair enough. That's good. That's what we want, right? I mean, that's how you learn. So, and I think that's the shift, because we've been so focused on predicting bad things, so focused. And we know really that's not particularly helpful. That's why we don't do it. We hesitate. We actually have a couple of projects where we do risk assessment with these approaches, but I'm not a believer, because if you have a valid risk assessment, it means you have a failed system. Because if you can measure somebody at time 1 and predict how bad they are at time 2, and if they are actually bad at time 2, you have failed that person, right? So a valid risk assessment is really just a barometer of a failed system. So it's sort of a setup, right? And so you kind of have to break out of that entire way of thinking about things. So I think you're right, Kate, that a success focused is better. We still have to be careful about all models are limited by the inputs you put in the model. So
Right.
every single model. So.
But the difference is you can connect these models directly to your data, and they are continuously learning from the decisions they made. You're adding an extra piece in that model that reinforces the decision next time. So it's constantly learning. You don't make one model, train it, and then, you know, in this traditional sense, and then apply it to everybody, whoever comes. You make a model that then is reinforced by how well it did every time it makes a decision and looks at what its outcome of that prediction was.
Right. I'll tell one story though, and that I agree with you. And I think, you know, Google has that down, right? They know what I want to shop for from when I look at Wayfair, and suddenly it shows up on my phone. So I had a professor as a early graduate student. He told me the following story. This is a story from the 70s, early 70s, late 60s. So this was back like in the protests against the Vietnam War, and you know, people like me were becoming hippies, you know, that kind of stuff, right? That was the time. And so he wanted to, he was teaching behavior, you know, learning back in the day when psychologists taught learning theory. And so he wanted to make a point that, so it was the big debate in our culture between, you know, determinism and free will and so forth. And so he wanted to give the message that, yes, we can control behavior. So what he did is he had an undergraduate and introduction to psychology class. And it was one of those big auditorium classes, right? And so he went there, he walked in the very first day he walked in, he had a tape recorder at the front, and he played the Star Spangled Banner. He walked halfway up the auditorium. He stood there with his hand on his heart and stared at the tape recorder. Over the course of the next few minutes, everybody else, all the students got up, stood up, and put their hands on their heart. He went down, he turned off the tape recorder. He said, "Don't ever tell me I can't control behavior." So what happened? He lost the class. They spent the rest of the semester trying to prove him wrong. So there is this problem that we create for ourselves by trying to predict things when you're dealing with human beings who like to prove you can't actually control them, right? So I think it gets to be a complicated set of dynamics that we'll sort it all out, but it'll be an interesting adventure. And I do think there's enormous promise to the machine learning kinds of stuff in the AI. I just remain perpetually skeptical. Perhaps because of that story, Phil Friedman and his introduction to psychology class. He could control behavior once, and he couldn't control it thereafter. So anyway.
Any more questions, reflections?
Not a question. Can I share the town hall that John and you also provided in New Jersey with the links so people can view? It just really expands. It goes in great detail.
Sure.
I'll put it in
Put
the
it
chat.
in the chat.
I will.
Put it in
Thank
the
you.
chat.
Just wanted to check.
Absolutely. Amanda, if you could ask Matt to come and we can all wave at him, that would be super fun, actually.
You want to come and say hi? Here. Come on.
Hi, Matt.
Hi.
Hello.
How's it going, Matt?
Thank you. There you go.
Hey. Hey.
Hi, Matt.
Hello.
There
You're
are people
welcome.
from all over the world on this call. I know Mark Kerr from England is on the call.
Alessandro from Italy is on the call.
Yeah.
That's his excitement for the night.
That was fun.
Kelly Francis
All
from
right.
Muskegon is on the call.
What?
That's
Shameless
almost fun.
Virtual garden talk we did earlier with Stephen Shimshaw.
Yeah.
Other
Any last questions?
comments, concerns?
So the PowerPoint for this presentation is not yet up on Socio, but it will be there by tomorrow. So if you want that, it'll be there. Some folks have asked me about more information on Communimetrics. I put my email in the chat. Please email me. I'll send you a copy of John's book electronically. But if you want to pay for it, you can go on Amazon. I think it's on there. It's called Communimetrics.
PDF is good enough. So
It was published in 2009. It's called Communimetrics. So it's not difficult to remember or find.
and Brian Shore is on the call, and so he's the man to talk to about publishing the research on algorithms. How you doing, Brian?
Very early stage, if I might add. Those days
sorry?
preceded the machine learning environment that we live in. So, but it definitely provided some groundwork on how one state was using the CANS algorithm at one point in time.
Very good.
All right.
All right. Well, we appreciate your attendance and your participation and your good work for others. And anything that we can do to be helpful, let us know. If you do decide to use algorithms, we just like to know what you're doing, just so we can weigh in. I mean, so I'll put it really, April said it sort of nicely. I'll put it in a way that I tend to talk. So, basically, United is being sued for its medical necessity criteria. So we've never been sued. We don't want to ever be sued. But if you get sued, we'll get sued. And so if you use our stuff, and so I think you want me in court. And the best way to have me in court is to make sure I know what you're doing. So that's kind of how we think about it. Doesn't mean I need to control anything. Doesn't mean we need to tell you what to do. It just means that we should be on the same page. So.
And John and I will hang out if you want to talk more with us. Otherwise, I hope you guys had a great first day. And we'll see you tomorrow. I'll turn this over to Michaela. She has a few more closing comments to make.
Yeah, thanks so much, John and April. I'm about to share the screen with the mine CANS code on it. So you should see that image up on your screens now. You can enter the key phrase into your Socio app to earn some points towards the leaderboard in Socio.
But no hyphen, right? It's just the word.
I believe it is just the full word. It just doesn't fit on the cube. So no hyphen. That's all I have. John and April can stay on and take questions, and enjoy the rest of the conference, everyone, and the rest of your evenings or afternoons, depending on where you are.
Thank you. Take care.
Yeah, thanks so much.
Dr. Lyons, if you don't mind, I had a quick question.
Sure, of course.
You were talking about the possible ethical problems with predicting risk. What if you go the other way? Is there a way to predict or program through strengths the success?